My talk is the psychological impact of COVID-19 on critical care staff and coping mechanisms used, and hopefully everybody can see and hear me quite well. This is research that we did during the first peak of the pandemic last year. It has resulted in 2 publications, and these are freely accessible, so I would encourage you to go and have a look if you so wish. It was a result of a huge team effort. You can see the co-authors listed, many collaborators. The staff at Tala, at St. James's, and the PICU in Temple Street in Crumlin were so forthcoming. We had 408 responses. Without the team effort, really, we wouldn't have been able to arrive at the answers that we did. We also, arising from this collaboration, we had a webinar earlier this year. It was very successful. Some of you may have attended. And in fact, there's a link there if you want to look back. The keynote address was from Professor Neil Greenberg from King's College London, who has done incredible work on moral distress. And his background is actually in the Defence Forces and the military, and the moral distress arising from scenarios that soldiers in conflict areas come across, but it has huge relevance for healthcare. And in fact, he has done a lot of work with hospitals in that regard. And also, I wrote an editorial earlier this year with some of the collaborators as well, which was published in the journal Clinical Nursing. Again, that's freely accessible there if you want to go and have a look. So the background to this research really is because we knew from early on that staff working through outbreaks in China in the early days, past pandemics such as SARS, H1N1, and the issues that were faced by adult intensive care staff. This included increased workloads, risks of infection, concern about infecting others, difficulties with PPE, and of course that moral distress that I spoke about. And this is associated with decisions about resource allocation in the context of needs and resource availability mismatch. We're facing that again at the moment. But there was nothing at that time published about the experience of pediatric intensive care or children's nursing and medical healthcare staff working through a pandemic. So that is why we sought to find more answers in the context of children's healthcare. So the aim of our research was to assess the degree of psychological distress experienced by healthcare staff working in both adult and pediatric ICU settings during the COVID-19 pandemic, and then examine coping strategies used by staff and the uptake of available supports. And our methodology, of course, was a cross-sectional multi-centre study involving 2 PICUs, that's Crumlin and Temple Street, and 2 adult ICUs, that's Tala and St. James's. It was an anonymous web-based survey, and we included all staff, all healthcare professionals involved in caring for critically ill patients in the PICU and the ICU. And these included, of course, the clinical and non-clinical staff, household staff, clerical staff, as well as social workers, dietitians, physios, nurses and doctors. And we collected the data. We just missed the peak of the first wave, but obviously we didn't realise at that stage that the pandemic would be ongoing. So the information we gleaned remains very relevant today. We used validated instruments to collect our information. And this one here on the left is the trauma screening questionnaire. And in terms of experiencing an item, binary responses, for example, please indicate yes or no whether or not you have experienced any of the following at least twice in the past week. And these include bodily reactions like a fast heartbeat, stomach churning, sweatiness, and dizziness when you're reminded of this event. A measure of more than 6 indicates an increased likelihood of post-traumatic stress disorder. This isn't diagnostic, of course, because these are self-report tools, but it does give us a good indication of the increased risk of developing psychological sequelae attached with this higher score. And the other tool, the measure of moral distress, and that's on the right of your screen here for healthcare professionals, it's designed for use among healthcare workers in clinical settings, and it comprises a list of the 27 scenarios that are known to cause moral distress and asks respondents to score the frequency as well as the level of distress associated with the event. And the last tool we used was the brief cope, and that lists 28 items representing effective and less effective coping strategies used by respondents to minimise the distress associated with negative life events. And I think it fits in quite well after the conversations we've just been having and the presentations you've just seen. So we have approach coping, which, as you can see from item 2, it's hard to read on your screen. I've been concentrating my efforts on doing something about the situation I'm in. So that's approach coping. And it's associated with activities like positive reframing, acceptance, actively seeking psychological support. And these are more helpful responses to adversity. The better physical health outcomes and generally more stable emotional responding is a result of that. And then in contrast to that, you have these avoidant coping strategies, like in option 4, I've been using alcohol or other drugs to make myself feel better. These are characterized by activities like that: denial, venting, disengagement, substance use, self-distraction, and self-blame. And they generally, people dip into avoidant coping now and again, but it is associated with poor physical health compared to approach coping. And it's proven to be a less effective strategy for managing anxiety. So we listed the available supports that staff had access to, and we asked them to rate these in terms of how useful they would be. And then we had some free text responses as well. Are there any factors relating to the current crisis causing you stress currently? Are there any obstacles or barriers to making use of available supports? What other supports would you or your colleagues benefit from but are not currently provided? Do you have any other comments or information about your experiences that you would like to share? So these free text responses added a qualitative dimension to our study. And a response, as I said, an excellent response rate of 59%, 408 participants responding. Understandably, mostly female. Nurses were 67% of the respondents, doctors 17.4%, and then allied health professionals 8.5%. Admin and support staff then represented 6.8% of respondents. So it's important to say at this point, even before the arrival of COVID to our shores, you don't need me to tell you that Irish healthcare workers were working in an overburdened and under-resourced healthcare system with severe bed and staff shortages. So it would be fair to say that the pandemic amplified existing workplace shortcomings, as well as exposing workers in the Irish healthcare system to new workplace stressors, with the shortage of, 2,500 acute care hospital beds, and then critical care beds shortage of about 300. We're short of 500 hospital consultants and over 1,200 nurses. So the results of our survey analysis, and the first section there sees the trauma screening questionnaire, and the result of 6 or higher, I'll remind you, indicates a likelihood of or an increased risk of post-traumatic stress disorder. And you can see there that those working in PICU were just as likely. So the nurses working in the pediatric setting were just as likely as their colleagues in the intensive care, adult intensive care setting, to score highly on the trauma screening questionnaire, with all the implications of this, given its association with personal turmoil, risk of substance abuse, burnout, suicide, and importantly, it can have an impact on patient safety as well. 14% of all critical care staff were at significant risk for the development of PTSD. And this is obviously very concerning, given just, all of those things. So looking at moral distress then, working in the adult ICU, a greater exposure to COVID-19 patients and redeployment to the intensive care unit were associated with higher moral distress scores. So very interesting findings there. And of course, when we look at the demographic and professional characteristics of the participants, over 50% of ICU staff stated they had cared for over 15 patients with COVID. Now, remember this, the first wave, while no PICU staff member had cared for that many, but nevertheless, the children's nurses were equally stressed, given, I suppose, the risks of redeployment and other issues that were causing them significant distress and stress and worry. Staff who cared for between, I suppose, up to 5 patients with COVID compared to those who cared for none, they were actually much more likely to have a higher measure of moral distress score. Staff who stated they had been redeployed, and most of these were working ICU, were more likely to have an increased measure of moral distress as well. So very interesting that being quarantined or working extra shifts were not statistically significantly associated with increased scores with measures for moral distress. So that's an interesting finding that came out. And if we look at factors related to high trauma screening questionnaire scores, being white Irish, scoring highly on the measure for moral distress scale, and using maladaptive strategies were all associated with having a higher risk of developing PTSD as a result of these experiences. And if I can focus your attention to the right-hand side, where the green and light blue bars are, these represent factors that cause much stress and extreme stress. The green and blue blocks. You can see that the standout sources of stress for ICU and PICU staff were worry about passing the virus on to family, concerns about the shortage of PPE, becoming ill with COVID-19, and the shortage of staff. So these are what cause staff particular worry. Now, if we look at the coping strategies that staff use, I mentioned approach coping. These are positive coping strategies, and all the benefits of those include its association with more helpful responses to adversity. Those I've marked with the green circles. And meanwhile, the avoidant coping strategies, they're shown to be less effective at managing anxiety. These are marked with red circles here. I think it's worth really highlighting that across all professions, there is a higher use of approach or positive coping strategies, acceptance, positive reframing, use of emotional support, etc. And interestingly, nurses had a statistically higher use of the strategies marked with asterisks. So nurses are more likely to self-distract, use emotional supports, to vent. I think we've all seen the venting, particularly in the coffin room. Now, venting isn't seen as a positive coping strategy, nonetheless, and behavioural disengagement isn't either. But nurses seem to use that as a coping strategy. The supports that participants reported as useful. It's important to know, because in an environment of limited resources where funding can be limited for these things, it's important to see that staff feel informal debriefs with peers, departmental debriefs of critical events, being allocated non-COVID duties. These are all seen as really positive and helpful. Public recognition is controversial. People don't really identify with the heroes label that is out there. Some do, then some don't, so it can be contentious. Mindfulness is seen as useful as well, and psychological support. But it is clearly the environments that colleagues and structures at work that members of every profession find to be the most beneficial when they're established well. And this feeds into a lot of recent literature that advocates promoting good relations between colleagues by providing organic spaces to interact, as well as open discussions about the good, the bad, and the ugly of clinical life. So here we mentioned the 4 free text questions that were included in the survey, and the responses to these were coded and themed into 7 overarching themes, and that you'll see here in the table. But really, these questions gave the respondents the freedom to express themselves. And I think the best way to represent that is to share a section of those quotes with you. Staff experiences. I have never been so stressed in my life. I was a ward nurse, put into an ICU with not enough support. After 1 hour of training, I was given a patient on ventilator dialysis. I was so scared that would cause harm to this patient. I think we all can identify with that, and how it would be very stressful. Social distancing and PPE is a barrier to providing compassionate care to parents of critically ill children. A lot of the children's nurses would have found that. I'm tired. I don't feel like I've been able to rest, as COVID information is everywhere and people are very tired. Teaching and training all stopped when COVID hit, and people that were on a professional training scheme, for example, felt that this all came to a stop. Doctors got to avoid coming near patients, but nurses stuck for 13 hours a day breathing in potential virus. Absolutely. And then, of course, going home and fear of infecting family members and small children. No childcare, minding 2 very small babies at home, and then going into an ICU setting to give my all. No downtime. Very, very stressful. So the above comments, they're all indicative of staff under extreme personal and professional pressure There were some positive comments such as, I am lucky to be working in a fantastic ICU where everyone supported each other, and medical preparation was excellent in ICU, staff and equipment was there. However, the truth is that these types of comments were actually in the minority. What staff need, not being able to take leave or rest days, knowing if myself or a colleague got sick, it will lead to intolerable increase of workload. Additional pay would be great rather than just being tagged as heroes or getting claps. So something that's tangible. Staff all expressed frustration at lack of information or knowing what was going on, and we did see, you know, no escape from all of the COVID information on one side, and then people feeling that there was not enough information, or perhaps it was the right information that they needed that they didn't seem to be getting. We need a quiet space to go while on duty. Debriefing on the unit, more support in work as opposed to outside of work. So people want, when they're out of work, they want to be out of work and not having to engage in work-related activities. A mental health day, not sick leave day. So some time to basically, you know, recuperate and recharge. I was kicked out of my accommodation of 3 years, and we did see this, that the accommodation issue in the Maslow's hierarchy of needs, shelter, you know, is such a high priority, fundamental right and a fundamental need. But the accommodation in rental scenarios was very, very difficult. So there is a lot of anxiety related to staff being that didn't have even the most basic of requirements. So conclusions and recommendations. The ICU staff have an equivalent risk of post-traumatic stress disorder compared to adult intensive care staff. Female workers, nurses, redeployment and greater COVID exposure is associated with higher stress scores. Extra organisation factors, major contribution to staff stress during the pandemic. Participants have ranked departmental briefs, peer support and allocation to non-COVID duties as more useful than established psychological and counselling supports. Staff need help with the practicalities of working in a pandemic in addition to clear guidelines and communication from management. And the message that came across loud and clear in our survey was that staff wanted to feel, firstly, heard, problems with accessing childcare, adequate rest, protection from exhaustion in the form of non-COVID duties were some concerns, to name but a few. Secondly, staff wanted to be spoken to. So a lot of it really comes down to communication. Many staff expressed frustration with frequently changing guidelines, poor communication of plans from their managers. Loneliness was also a big theme in our findings. The loss of communal spaces at work was keenly felt. And this compounded the loneliness of not seeing friends and family and loved ones outside of work. A particular mention should be made with regards to the many healthcare staff working in these hospitals who were originally from overseas. There was so much anguish expressed by these people about the severity of the pandemic in their own home countries, as well as their grief at not knowing when they would be able to see their loved ones and return home to be with them. And just to say, the supports that were ranked most highly by the staff, they are easy to facilitate, peer support and departmental debriefs, rather than the formal, you know, psychological support mechanisms that might be needed. It really is that I suppose the environment and the peer-to-peer support that people found so supportive. Some supports were ranked less highly, such as the employee assist program or psychological support. And there are barriers that exist to accessing these supports. And now I've heard mixed feedback about the employee assist program ever since, and I do think they've, you know, resourced the EAP more, and it's improved a lot from what I gather. But if there isn't time off to facilitate attendance at such supports, then that's going to be a barrier. And what we also found, which is quite interesting, is the stigma around accessing psychological support, that those in the caring professions feel that they should be able to cope with these demanding scenarios, and that, you know, even linking in with psychological support services, contacting EAP, you know, is all done very, very secretly. And on the one hand, there can be an impact on career, particularly for the medical professionals, if there is any kind of psychological issue revealed, it can have an impact on their career and future employment. So that is something that we are hoping to look at. And there is a cultural shift required. There is a real sense now that psychological well-being is a professional responsibility, that you have to look after your psychological well-being before you're able to look after anybody else, and to value ourselves and to normalize help-seeking behaviours, to normalize accessing psychological well-being support. There has been some headway in that in terms of setting up the PICU well-being. There's a well-being committee, and that is in Children's Health Ireland now. Mona Baker is the lead for staff well-being in CHI. So there are changes coming, but it will take a shift in culture, and it starts with early career nurses as well, and certainly when we have them in college. And on the grad dip, Eileen, you will certainly vouch for the fact that we do place a huge emphasis on looking after, the psychological well-being, that's part of professional responsibility, self-care. So to really acknowledge the team that were involved in this research, Dr. Tara Feely is in Auckland, Robert French O'Carroll is now in Canada. Mong is the research nurse in PICU, who is incredible, and we wouldn't have gotten that response rate if it wasn't for Mong's determination. Kylie is on maternity leave. She's a psychologist in CHI, Catalin Enda in James's, and Barry Lyons, who is our consultant anaesthetist and bioethicist. And you'll all know Suzanne Crowe, who is the president of the Irish Medical Organisation, and everybody who took time to complete survey questionnaires. And we now want to look at the impact of the HSE cyber attack and the subsequent IT shutdown in the context of the pandemic. And we have applied for ethical approval to proceed with that kind of research, and also to look at the wider issue of stigma around accessing psychological supports, and also the role of staff in supporting each other. And if staff are relying on each other for support, what kind of support is available for the staff that are supporting their colleagues, because that's really, really important. So Eileen, I think I leave it at that. And if anyone has any questions, and as Eileen said, the presentation is available, and those publications and links are available for you as well.